back to the Group Practice Accelerator podcast, brought to you by Polaris Healthcare Partners, where we leverage decades of healthcare and business experience to drive growth in successful group practices just like yours. If you're a healthcare entrepreneur and you're interested in building, scaling, or exiting your group practice, you've found not only the industry's leading resource for business education, but a team of trusted advisors dedicated to helping you achieve and exceed your goals. In short, the team at Polaris creates clarity, confidence, and results. I'm your host, Jamie Falosh, and the Group Practice Accelerator podcast is on the air. Well, hey everyone, thanks for joining me today because we're going to be talking about building, but not in the way that we've chatted about recently in terms of building your group or scaling. Today, we're going to talk a little bit about building doctors. And well, what does that mean? So when we talk about building doctors, I want you to think about creating leaders in the operatory, leaders in the practice, leaders in case acceptance, meaning they know how to, in turn, lead patients by gaining their trust. And as we get into today's conversation with our guest, I want you to really take in how some of those techniques and recommendations that you'll hear can impact your business. So without further delay, I'd like to welcome back to the show group practice owner and leader and Polaris Clinical Coach, Dr. Vivek Solanki. Vivek, welcome back to the show.
Hey, thanks for having me.
Always good to see your smiling face.
How are you?
Good. Ready to roll here today. And I know we were talking, before we hit the record button a little bit about, building leaders and how that
hmm
happens, because I think everybody knows by now you've been on the podcast a number of times and you're a group practice leader. You've done this, you've walked in their shoes, so you're a great resource.
Absolutely. It's a fun, exciting journey. And yeah, couldn't be happier to share what we're doing here at Polaris and what we've also implemented into our own practices to help make them successful.
Absolutely. And that's the kind of thing that really helps our audience. It's what you've done that you find that works, right? Because they can go back and apply that. But, before we hit record, you and I were kind of discussing the building blocks and the strategic importance of empowering the GP, right?
hmm
But
hmm
I want you to rewind a little bit because I don't want to get ahead of ourselves. Can you tell our listeners what you mean by strategic importance before we start going into how this is built?
Yeah, absolutely. So let's think of the dental office. The most basic dental office, what we all know is a general dentist in that practice.
Right.
This would be the simplest thing. They're doing their own hygiene. Okay. And
Mhm.
then I guess the next level up would be a general dentist principal there with a couple hygienists, right? Now they're running their own hygiene program. They're doing their own hygiene checks and they're managing their own schedule. Let's go a little bit higher up. General dentist now has an associate or two, and they have a hygiene program. So now what they're managing a hygiene program, they're mentoring their associate doctors, they are managing their own cases. They may or may not be full-time in the chair, and they may or may not be dedicating some time to admin and helping train the doctors.
Okay.
Next level up, let's look at the multi-specialty model. Now you have GP, associate GPs, you have a specialist coming in. Maybe they bring Vivek in to do travel perio once or twice a month, and they have an OMFS come in. Now we start leaving this general dentistry bubble, and we're now moving into like a multi-specialty group practice.
Right.
And then that's kind of, you can go so much further. What type of scope of services are we providing? Are we doing teeth in a day? Do we have an in-house lab? It can get very big on how you go in terms of what different specialties you bring into a practice. But that's kind of what I want the audience to think of it as. And when I say the strategic importance of having the general dentist as the starting point, is because nothing can build to those skyscrapers until that foundation is pure. Like you have to have confident, strong GPs because they are still the quarterbacks in clinical dentistry. Everything starts with the restorative model. What is our treatment plan going to be? And then let's funnel people through the departments in our office where they need to go so patients get the right care they need and efficiently. We don't want to drag people's cases out forever.
Right. Oh, that makes sense. And really, that speaks to the foundation of the practice, right? You get a confident, strong, great case acceptance presenter someone that can communicate well with doctors, someone who is growing clinically. That's your foundational piece. And if you don't have that in place, why bother building on the rest, right?
Exactly.
Okay. So now that we understand that strategic importance and how that kind of builds on itself, and only, I'll reiterate here because we talk about this a lot on this podcast, only if you have that strategy laid out for yourself. A good strategic plan is, in my book, just like an SOP. You've got to have that
Hmm.
laid out first. So
Hmm.
now let's talk about the building blocks of putting
Hmm.
that together.
Usually, when people come to us at Polaris, the principals have the common question that I get, from talking to dozens of doctors who are asking there's similar pain points and there's similar questions. And this goes to building block number one is I'm in the chair and I have associates, but they're not doing what they could be doing, or I'm not happy with the level of production that they have. Usually it's not really like a monetary goal. It's just that the principals are in the chair so much that they don't have the time or they've never done it to a degree where they can duplicate their process and take, if the right doctor with the right mindset comes in, help them go from a 15, 1200, $2,000 a day production to five. Let's just call it a baseline level five.
Okay.
So that is really building block number one. And I'm going to speak to the audience as if you are all principals that needed help with your associate doctors. And building block number one is really understanding where the associate doctor is. And what needs to happen is, you need to sit down with these doctors and understand what their clinical goals are.
Okay.
And you also need to understand what they're afraid of doing. The two things that stop us from doing things is usually fear of failure, fear of unknown.
Do you find that doctors are okay with admitting that, or do you kind of have to work on drawing it out a little bit?
You can, you may have to, I have to pull it out of them a little bit.
Hmm.
And the way I do that is by taking a really objective approach is let's treatment plan this case together.
I like it.
And you'll understand, treatment planning should be fun for all of us as clinical providers. If you don't like treatment planning, then there's a problem,
Yeah.
because you should be able to look at a case and just this is what I teach. Within 5 minutes, I want you to tell me, is this an all on X? They can't afford it. Okay, great. What are we going to do next? Let's extract these 5 teeth. Let's do a bridge here. Let's do a partial here. If they can't afford that, what's the next step? It shouldn't take you, 5 days to treatment plan a full mouth rehab.
Right.
You should be able to know based on what this patient's financial means are, and without overextending them, how can we get them healthy in our practice without dragging this thing out for a year? And how can we get their smile back and get them disease decay free? So
Yeah.
if somebody can't do that fast, there's a problem.
Yeah, and that's really the end goal, right? Patient care is the goal of doing all this in the first place. I mean, you went to dental school, isn't that part of the whole
Mm-hmm.
package? But I really like that you take that objective approach and take that uncertainty piece out of it, because if you're doing it together, that allows everybody to contribute. And while nobody likes to admit that they're not perfect at everything, we're not perfect at
Sure.
everything. Everybody needs a mentor.
Absolutely.
Everybody needs a
Absolutely.
mentor. Yeah.
And perfect example, we do a lot of all on X in our business. A lot of my all on X personally is limited into conventional all on X. And now I'm doing something called pterygoids and maybe dabble in some zygomas in the future, right? Because I'm turning away patients that I could have treated better if I had those tools in my toolbox. So I'm
Oh,
still
yeah.
learning as well. So,
I like that.
with building block number one, when we sit down, or when your principals sit down, how would you treatment plan this case? You want to see where they get stuck, right?
Good
You'll
point.
understand it. I'm not sure what to do. You'll see their hesitation. There'll be silence. They're
Yeah.
not sure. Do I want to take this tooth out? I would say 90% of younger doctors feel bad telling a patient that they have to lose a tooth. And
Sure.
what the thing I tell them is, like, you didn't put this decay there. You didn't put this
No.
disease there. You're just you're fixing it. So
Yeah.
remove the emotional component here. And like if this was any x-ray, what would you do here? I would take this tooth out. Why? Because it has a poor prognosis. Why? It's restoratively, there's no margin. There's going to be nothing left when it's all done. Great. So first step one is really understanding how they treatment plan, and you'll get an idea if they're thinking forward thinking, like, oh, let's get a single implant here. They may say things like, let's do an extraction bone graft here and let's get it ready for an implant in the future. Can you place the implant? No. Well, maybe I'll learn, or we'll refer it to the specialist.
Yeah.
Versus the people who only have a hammer in their toolbox, then it's everything's going to be let's do a denture here, a partial here, and they're condemning too many teeth, or they just don't know. And that's going to tank your business. It really is. It's going to
Yeah.
destroy your business.
Yeah. Because if you don't open your toolbox and add to it, guess where you are?
Mm-hmm.
That's a downward spiral. But I do like that you take that approach and open it up and read where that person is. I think that makes
And
it.
then that's sorry, I didn't mean to interrupt. And that's where you'll get an idea of how to start their next level of coaching.
I like
You
that.
know, whereas it's now treatment planning has become like a fun thing for them, and it's now an avenue where they can feel a sense of relief that they're not in this world by themselves, and they will start coming to you and say, hey, I've got this case and I think I want to treatment plan it this way, what do you think? And that's what you want. So if you do step well one, what you'll find is that the docs will start coming to you and saying, you know, what do you think about this treatment plan? And then that's where you can start to mold them and help prevent them from the same mistakes that we all experience, you know, trying to do herodontics. Like, let's not do that.
Like that word. Something tells me there's a story behind that. Maybe we'll have that another day.
Separate day.
Okay, so you said you talked about the first building block. First of all, how many are there? I want to make sure I don't miss any.
You know, let's keep it simple and say, you know, there's 3 to 4 building blocks. So you can combine
Okay.
a couple of them to one. So the first step is understanding where they're at so
Hmm.
that you know where they need to go.
Okay.
And step in building block number two, we'll call that drills. And I know we've talked a lot about drills
Yeah.
and how can we get the desired change that we want. We can't do it verbally. So first step is a lot of verbal understanding, listening. You
Hmm.
know, the dentists that are doing this as principals, they will understand a lot from the doctors coming in just by doing 5 treatment plans. They'll figure out where the doctor is at in terms of comfortability and what they've been exposed to in terms of the landscape of what all can be done in dentistry,
Sure.
and then how to navigate something that may seem complex for us, but how to make it simple so that it can be told to a patient that's going to make the doctor feel kind of confident, and it's going to instill confidence in the patient. So that's all part of step one.
Okay. And then, step two, when you talked about drills, can you walk me through like an
Mm-hmm.
example of a drill?
Yeah, so I will pretend to be a patient with my docs,
Okay.
and so this is exactly how I do it for the audience. So please, try it this way, because if we did a drill right now, Jamie, is you as hygiene, and I would say, I'm the patient and I need SRP. How would you tell me? And then most of the time, the docs will say, well, I would say this. I say, no, 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 do it real, do it for real. Like, I'm a patient,
Yeah, actually
and
role play with it. That makes
role
sense.
play.
Yeah.
And you're gonna be shocked because people are gonna have to do this like 10 times before the doctors actually do it correctly. You're gonna have to say stop, start over, because they're gonna go into this third person narrative. Well, and I would just assume that. No, 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 don't assume.
Mhm.
Don't speak in third person. Don't assume. This is the real consult. Do it for me right now. I'm the patient. Here are my x-rays. This is what my treatment plan is. Now tell me what is going on. And it's eye-opening. It's
Yeah.
nervous for them. It's hard for them. They get frustrated. They get angry. They get
People hate role
nervous.
playing. I hate role playing. But
But
you know
you know
what?
what?
It works. It works.
The next day you just gotten like 15% better in case
Yes.
acceptance. And the doctors, although they had a shitty experience the day before, the doctors come back more prepared the
Yeah.
next day and they're stronger the next day. And you see the fruits of the work and the labor in impact. It empowers them and it impacts the practice significantly in such a short amount of time.
Well, sure. And I think that we all think that we are exempt from needing to practice or run drills, no matter what it is in your life. Nobody goes out on the baseball field and hits a home run every time, or even a single. Even on this podcast, starting back in January, this requires practice. All of it does. Not that you don't know how to have a conversation, but it's getting into the cadence of your work and really experimenting with conversations and things that work with the patient. And
Mm-hmm.
certain things resonate and certain things don't. When you talk about bacteria with a patient and how that affects the whole, the periodontium, you see people glaze over. And I'm sure
Glaze.
it happens. Then you learn how to simplify that. You learn how to make
Mm.
it impactful so that it does resonate with the patient. So I love that you are an advocate of that role playing and really force that one-on-one conversation rather than shift to third person, because that's real easy to do in practice.
Yeah, absolutely. It is. And it's something that many principals don't want to do. But
Yeah.
if you can just carve out, you know, 2 hours a month, bi-weekly, an hour session, just like you have a morning huddle with your team, just sit down with the doc during lunch or after work one day and put up like maybe 3 or 4 treatment plans and just say, assuming like you keep it simple in the beginning, assuming there's no perio disease here, and all you see is non-restorable teeth and restorable teeth, and they
Yeah.
have the FMX there, so the docs know. Just walk me through this. So you're trying to get these circuits in their brain to start moving faster, right? You're trying to get them to, in their head, there should be the associate doctor. I'm going to tell you both sides of it. So the associate doctor should be saying, okay, well, I can save these. This is how I do it with my doctor. So I can
Mhm.
save these 9 teeth. Tell me what has to go first. Now that you've kind of cleaned the room, we can go furniture shopping, right? So like, tell me what has to go first. And now how are we going to rebuild their occlusion? And not every case has to be a full mouth rehab. So you want them to start taking something complicated and simplifying it. And then when they do it, do the drill, when they tell you their treatment plan as you being, this is for the principals now, as when they tell them as the patient, hey, Mrs. Jones, this is what's going on. Listen to the words that they're saying. I think we could. Those
Passive,
words don't
passive, passive.
instill. Yes, they don't
Mhm.
instill confidence. Like if I went to the cardiologist and he's like, I think you could do this, I'm going to be leaving and going and finding another cardiologist because I don't want to think that I'm going to be alive in 6 months. I want to know that I'm going to be alive in 6 months.
Save the I thinks for philosophy and opinion outside of your professional.
Exactly. But this is eye opening.
Hmm.
Most people don't realize, even now, I have seasoned docs in my group. They're fantastic. My doctors are awesome, but we'll do drills now. And I was like, interesting, because now they're doing drills on closing full arch. I have some GPs that are closing 6 arches in 2 days for all on X. And that's meaningful to them. That's meaningful to the practice. And that's high end dentistry that they're learning to execute on. But when their case acceptance drops and we see things in the practice changing, sometimes we have to go back and do drills again. We have to go
Yeah.
back and figure out what is it that changed from something that was working.
Well,
And these
this,
drills are very powerful.
yeah, I was just going to say this really seems like a big part of the foundation because I think often too we tend to talk over people. When you reach a level of education and you're excited and proud about that education, which is natural, we tend to fly through all these details that again makes people glaze over. And if they don't
Mm-hmm.
have a good comprehension of what their treatment is, they're
Mm-hmm.
not as likely to accept it. End of
Mm-hmm. You're
story.
right.
Yeah.
Mm-hmm. I agree with that. So
Okay.
in
So,
this,
mhm,
yeah, sorry. So in this second block of the drills,
mhm,
the principals, team members, doctors, anybody conducting these drills, the goal is to correct language that seems ambiguous.
good.
It's to make language something that is something that a elementary school person can understand without demeaning the
Yes.
patient.
Yeah, exactly. And you have to do that. It might
Mm-hmm.
really sound like an elementary school education. However, that is how you have to deliver a lot of
Mm-hmm.
things because again, we talk over people. It's just natural.
Mm-hmm.
It's not, it's not anything that someone sets out to do to, make it confusing. It's the natural way we do that when our
Mm-hmm.
education is elevated.
Exactly. Eliminate verbal diarrhea. I tell that to my docs sometimes. They just sometimes you just keep talking and enough is enough.
Yeah.
Like the patient understands. And then, the call to action, which is so important, closing, right? And that part of the drill is getting the doctor comfortable saying, they don't have to say, I need your credit card. Like that's a little too much.
Yeah, we'll
But
leave
they
that.
have to be able to say, I want to see you next week to get X, Y, and Z done because if you're genuinely concerned, like if you were treating your family member, I say this question to my docs, like if you were treating your husband or your family member and they had a bombed out number 30, previously root canal treated, massive radiolucency, and then I ask them, what would you tell your loved one if they presented with this? They would say, "Oh, you need to take it out," and that's nonsense. You wouldn't say that. And what would you really say to them? And eventually, after asking them the question like 6 times, some of them get to the point where they're like, "You're not leaving today. I'm gonna take this out, and you have nothing you can say about it." Okay, so now let's just take that message. You don't have to do
Yeah,
that to your patients, but that level of care, like if somebody knows that you're genuinely there to help them and that you're concerned about helping them,
right.
there's a different patients can understand the intention that you are taking to help them. And so the goal of those questions is just to get the receiving end of the party to understand the intention is that I'm concerned about this. And the why I'm concerned about this is because of these reasons. And this is what I want to do to help you and take care of it for you. And most people will understand that and move forward. But if the doctors can't say that and they're not comfortable having those conversations, which you will learn in these drills, then you're just burning all this chair time for the next guy down the road to just say the same thing and spend 90% less because you've already done half of the consultation for them to just get the patient closed so they can do the treatment that they needed.
I like that you use that because when intention is not very closely tied to concern, it's simply a transaction and there's no sense of urgency. All right, we covered drills. What's next?
The next is implementation phase because now you are pleased with how they are having these drills. You'll see improvement. When we do clinical coaching, we see a lift in the first 3 months because the drills become, they become, it's like residency. I did 5 years of residency. Anybody listening who's done 5 years, like multi years of residency, we all hated residency for a reason, but we'll never trade it for the skills and the knowledge we've gotten. So
I'm
the
sure.
drills are designed to be that way for the doctors coming out into the practices. In implementation phase, you're now watching and you're listening to how they do it with their patients. And there are things that you may have to help them with. You may have to be in the room with them. You may have to, have them do drills a different way. But you'll see that not everything from the one-on-ones translates over to the patient. Some people will
Hmm,
knock it out of the park. Generally on simple things, occlusal fillings and MODs and crowns, they'll feel comfortable with that because it's what a GP is trained to do a lot of.
sure.
But a lot of these GPs want to place implants and they want to do overdentures and they want to do all on X. And when the patient says, how much is a double arch going to cost me? And they have to tell them it's $40,000 sometimes that's hard for them to go from talking about fillings and crowns to talking about 3 patients who need $120,000 worth of work in your schedule today.
Oh, right.
So you're going to have to, in the implementation phase, there's a little bit of overlap where maybe they do the consult first and you do the consult with them, or you listen to them and you see where they're getting hung up. Are they using the right visuals? Are they explaining something to the patient in a way that the drills were designed to do, something that a child could understand but not demeaning to the patient? And so in implementation, you'll see, oh wow, I see where it's almost there, but there's a small couple tweaks we need to make.
Okay.
And an implementation phase is also where, like when I'm a coach, this is where I go in and I help docs with treatment. A lot of times I'm suctioning for docs when they're placing their implants. And maybe I have to like move their, handpiece a little bit, just redirect them, and then I show them why. But after like 5 times, they know what to do. They don't need my help. Or implementation maybe with doing simulations on a model. This is how we do crown lengthening, and this is why we cut bone this way. This is why we prep your implant site this way. So these are all things that I do with my GPs to adjunct their clinical toolbox. We're not talking about them doing wisdom teeth extractions, second molar endo.
Yeah.
I've picked these cases because, one, these are the things that most GPs desire to do. They want to do their own extraction bone grafts. If you have to survey them, they want to place their own implants and restore them. The ones that don't need sinus lifts and bone grafting and anteriors and immediates. Then there's a lot of GPs who are comfortable with single implants, but they want to learn immediates. And then you can help them with that. So there's so many different drills outside of the treatment planning drill that we do on simulation side. And implementation side, it's chair side, helping them, watching them, getting to the point where that they're comfortable managing them on their own, which may take 3 to 6 months, and watching them before moving anywhere further.
Okay, so I have a question on some of those drills. One of the other things you and I chatted about the other day were production ceilings. Can those drills help prevent production ceilings, and help me understand that a little bit?
Yeah. There should never be a real production ceiling in an office, and if that is happening, then check treatment planning first, and
Hmm.
then check how they are providing treatment and scheduling next.
Okay. And
So
I
the
was going to ask the
production
same
ceilings.
question about mentorship. So I should probably just ask you,
Mhm.
how do
Yeah,
mentorship and drills help prevent that?
absolutely, 100%. Because they're only going to treatment plan what they are comfortable with, and
Yeah,
they're only going to schedule what they feel that they know how to do without, feeling like they're going to make a mistake, because
right.
nobody's there to help them or bail them out if they do make a mistake. So
Yeah.
then how are you supposed to expect somebody to just miraculously go from 3,000 a day to 7 if they're doing the same thing they were doing for the last 2 years?
No, that's not growth.
So the drills will help. Maybe you do the drills and they close the cases, and then maybe you give them like double the time for that implant placement, or more schedule soft, a little bit lighter that day, so that they can spend more time with that patient. And then they have this win where they did the treatment, you were there, you watched them do it, you helped them, they got the win. Okay, great. Now you will start to see those ceilings break, and
Okay.
they will create new ceilings for themselves. And they now go to a average $5,000 to $6,000 a day producer. They're comfortable with most surgical extraction bone grafts. They know when to do crown lengthenings for their cases. They're placing some 5 implants a month.
Sure. And you've just moved the bar up for yourself every time
Mm-hmm.
through that mentorship and drills. So
Mm-hmm.
that's a great solution.
Most Absolutely. And most doctors, I say like the majority of the doctors that I've worked with, most doctors will come to you to get that next level of growth. Very few will say, I don't I have had a couple who say this, that I'm comfortable. I don't want to do implants.
Okay.
No problem. You don't have
Yeah.
to do it. You don't have to do it. But the fact that you understand it and that what needs to go into it, at least you can treatment plan it and somebody else will do it or something like that, you know?
Yeah.
So
It's,
most will do it.
well, and it's good to recognize what you do and don't want to do.
Hmm.
That's all right too. This is not, something that's mandatory for everyone with a license. But
Exactly. And you have to respect that, right? And if you
yeah.
don't want that in your office, then find them a different home, right? This is not a dental office is not a family. Families are dysfunctional. We are teams,
Good
right?
point.
Teams. Families have problems and families are dysfunctional, but teams trade players. So
Yeah.
if your goal is to get your team to a certain place, look at how many times LeBron and all these people have gone from team to team. So if
Oh
you
yeah.
want,
Got it.
you got to trade them,
Yeah.
and that's the thing that a lot of people are afraid to do. And you're doing both parties harm because you're trying to push your doctor to do something they don't want to do, and then you're expecting them to deliver on something that you want your business to do, and that it doesn't work like that. So find the doctor who wants the mentorship, who wants to grow within your practice, and then do these things with them, or hire somebody to help you do these things with them so that your business can get the growth that it needs. And for all the listeners out there, I'm not talking about EBITDA and all these numbers, right? I'm talking
Yeah.
about the stuff that we do all day long. This is dentistry. Come on, this is what we train to do.
Yeah. And you have to have somebody on your team that aligns with you. So
Most doctors want to learn and grow, and they
agreed.
want mentorship, and they want somebody to help them. They genuinely want that.
I would double down on that. Like we talked about at the beginning of the podcast, there can be a little hesitancy in admitting what we don't know or we're not comfortable with, but I can say pretty confidently that once someone recognizes that this process is really a growth process, that boy, I'd be on board for every level that I can step up my game in terms of patient
Mhm.
care. And of course, the
And
broad
they'll
potential of it.
shine. Yeah, exactly. I mean, at the end of the day, it's good for all parties. We say that so much, right? It's good for the
Yeah.
practice, it's good for the patient, it's good for the doctors as well.
Yeah. Good point. And while we're talking about leadership and those developmental strategies, like what are your two most effective? Because we'll keep it to two. I'm sure you have dozens.
Hmm.
Like, what are some of those strategies that support like long-term organizational growth? Because to this point, we've talked about some steps. So let's look at that from a long-term lens, because I know you, having your own group, have experienced this and must have some strategies in place.
Yeah, I spend the most amount of time treatment planning,
Hmm.
and I'll say treatment planning and communicating with patients. That's number one for me.
Okay.
And the drills and implementation phase. That is number two, because
Yeah.
those two things are going to allow me to empower the docs, and it's kind of like this organic growth that you see happen over time, because it's not a one-time deal. You don't just do a treatment planning one time, and you don't just do drills one time. You're
Right.
constantly doing it, because as your docs grow, I'll use one of my docs. So you have a new grad. I love working with new grads because they haven't developed bad habits yet. And
Good
so
point.
the new docs come in, they're hungry to learn. They're like a sponge, and you do these drills and you do these things with them. And some of my young grads are running circles around seasoned docs. It's amazing.
Wow.
And it's because they listen, and they're hungry to learn, and they close cases, and then they come to you like, hey, I have this implant next week. Will you be there for it? Sure, schedule it. I'll watch you. They all they want to hear is to say, I'll watch you, or I'll be there. And you don't
Yeah.
really have to do anything, because you know that they're capable of doing it on their own.
Sure. And I think when you are leaving school, that we tend to lose a little bit of that excitement,
Hmm.
right? And I think that your mentorship and these drills and these programs that you can put together and that you've seen work can make a huge difference in bringing back that excitement to doctors and really keep them leveling up their skills.
Yes, yes. And I agree, exactly what you said. There's so many things that the leadership tools, but number one, how your doctors can communicate with patients and treatment plan, number one. And then the drills that we do or your principals are supposed to do, the drills, the implementation drills on helping them execute what you're trying to teach them, those two things should be in every clinical protocol for culture development and retention in large group practices.
Yeah, that's a mouthful right there that you just said. All of those elements. And Vivek, I'm so excited every time I'm going to have you on the show because I love these conversations with you. Thank you so much for coming on the show today. I know that you have a crazy busy schedule, but we love having you.
Thanks so much. I appreciate it.
Well, I know our audience values your experience, not just in that clinical development sense, but the fact that you've walked in their shoes and built your own group. So that's really got to resonate with them. So appreciate the time.
My pleasure.
To our audience, we appreciate you as well, that you support us by subscribing to the podcast. And we love the questions you all send us. So keep those coming and we'll keep delivering the content that you ask for. So as always, if you want to learn about any of our Polaris expert advisory services, or maybe there's a topic that we haven't covered yet that you'd really like to hear about, please send us an email to info@polarishealthcarepartners.com, or you can always go on the website at polarishealthcarepartners.com and hit that little contact us button and send us a question that way. So thanks again for being a loyal listener and subscriber. If you enjoyed today's episode, please share it with a colleague and be sure to leave us a rating on any of your favorite podcast platforms. We'll see you on the next episode of the Group Practice Accelerator Podcast.